Thanks, Matthias. So it's my very great pleasure to introduce Alice Coombs, who I've worked with for almost 5 years now. We were basically a duo that drove change down in Virginia. And she has an outstanding pedigree. She was board certified in critical care, anesthesiology, and internal medicine, and is a fellow of the American College of Chest Physicians. She was chair up at South Shore Hospital, affiliated to Brigham and Women's, before she came down to Virginia, and she's now full professor and chair at Virginia Commonwealth University, where I was before I moved to Penn. She was, when she was up in Massachusetts, she was elected as president of the Massachusetts Medical Society, which, as you know, is the owner and publisher of the New England Journal of Medicine, and she served on the Committee on Publications as well as chair of the MMS Board of Trustees. And in 2005, received the Massachusetts Medical Society's Henry Ingersoll Bowditch Award for Excellence in Public Health. And that's an annual award which recognizes a physician's demonstration of creativity, commendable citizenship, initiative, innovation, and leadership in the public health and advocacy fields. She also got a master's degree in public administration from the Harvard Kennedy School. She has extensive public policy experience focusing on the impact of ACA and MACRA, and she, as Medicare Payment Advisory Commissioner for 6 years, helped to make recommendations to Congress regarding Medicare payments to physicians, hospitals, and other providers. And every Thursday afternoon, I understand she used to go for afternoon tea at the White House with Barack Obama. She is also an AMA delegate elected to its Council on Medical Services, and she's the member of the AMA Commission to eliminate healthcare disparities. And she spearheaded the development of the Healthcare Diversity Educational Toolkit. She's a driving force behind the AMA's Doctors Back to School program, and she's also the National Medical Association Anesthesiology Section Chair. So there's no one more qualified than to give our keynote lecture, Equity of Healthcare in the USA and the Role of ERAS. Thank you, Alice. We welcome you to the stage.
I have to thank Dr. Scott. He is a phenomenal individual. And I thought that my life was going to be just okay, because when he came to VCU, I said, oh, great. I look forward to working with him as chair of the Department of Anesthesia. And then he left me. So I really appreciate you, Dr. Scott, and all that you've meant. And what you're going to see today actually is a representation of his hard work. And he had a lot to do to change the culture at VCU. And he single-handed, in conjunction with some other people who came alongside of him as time went on. So it's like really huge. I'm excited to talk about healthcare disparities because it is who I am. And I just want to, these are my disclosures. Objectives of here, and we're just basically going to talk some historical strategies to reduce healthcare disparities, talk about bias in decision making, which I could talk for hours, and I only have 30 minutes. I say that to myself, to control myself. And then we're going to talk about ERAS strategies to reduce healthcare disparities. So my background, I grew up in Compton, California. My mother was one who went from neighborhood visiting various sick people, and often I would be curtailed to go with her. And I always asked, Mama, what's wrong with Mrs. X or Mrs. Y? And she would say, oh, you know what? They got a potassium problem, and she goes to the bathroom a lot. Only to find out later on that Mrs. X, who lived across the street, actually had colon cancer and had diarrhea, and they gave her potassium to keep up with the diarrhea, only to die of metastatic colon cancer. That's what I learned in the process of going to different people's houses in the neighborhood. Fast forward, I trained at Mass General because someone told me that was a great place for me to go. It literally changed my match list in medical school because it was recommended that I go to Charity Memorial because they had some very good expertise in managing tuberculosis, and that was my number one prior to my advisor changing my match list. My family background is many disparities. I get a call, almost weekly, someone telling me a particular story about, what do you think about that? And I love the fact that patients are empowered to ask questions. We'll talk a little bit about that. Quality and safety and public policy. This is huge. ERAS should be right in the center of this. And we focus so much on the quality, but until we get to the message of ERAS is also improving serious safety events and reducing them, that is a chapter that everyone's looking for a value proposition. So let's start off distinguishing between health disparities and healthcare disparities. So health disparities are preventable differences in burden of disease, injuries, violence, or opportunities to achieve optimal health. And commonly described with socially disadvantaged, racial, ethnic population groups and communities. Healthcare disparities is what happens after you come in contact with a healthcare system, a provider, and those are differences in outcomes related to the delivery of healthcare or prevention. The Institute of Medicine in 2002 did their bold publication, which transformed the landscape of healthcare disparities, basically telling us something that people kind of thought about, but they did the literature and the data to say that as part of the Academy of Science, and that was that disparities exist with minorities, Latinos and Blacks. They get treated differently despite them having the same income, despite them having insurance coverage. And that was really bold back in 2002. Disparities also exist for gender, disability, and sexual orientation. And there are multiple etiologies for healthcare disparities. And anyone who comes in here and says, I think we've got to reduce health disparities, let's just do diabetes. Let's do vaccinations. A single lens effect is a low-hanging fruit, but I don't want us to be fooled and lulled into the low-hanging fruit apoplexy. You can do that, but there's much more of a larger scale that we should be working on to reduce healthcare disparities. This is a case that happened. Unfortunately, this woman was in the lobby of the Martin Luther King Hospital back in 2007, and a call was made from the waiting room, and they recorded the call on a 911 call, and they said she's passed out, she's vomiting blood. This woman actually died in the actual waiting room. And so because of the 90 minutes of this woman, we ought to remember this, and this should be an impetus for us to move forward. This very story is disheartening. It's how someone has access, but they don't really have access. They're actually in the umbrella of protection, which is a healthcare system, and yet the healthcare system does not do right by them. Amputation versus limb salvage surgery. Here it was quoted almost 15 years ago that African-American male is nearly five times more likely to have an amputation rather than limb salvage surgery, or an angiogram for that matter. Okay, so where you go does make a difference. What hospital you're admitted to with COVID-19 made a huge difference. But guess what? We knew this long before the pandemic. And I'm going to give you some examples later. So of all the things I've done for the commission to eliminate healthcare disparities, I was on the Governor's Commission, I was on the AMA's Commission. We sit around the table and everyone talks about, oh, well, how do we get rid of these healthcare disparities? Hours, I cannot tell you, for 10 years straight on one commission, and another with all of the legislators involved with the Massachusetts Governor's Commission to eliminate healthcare disparities. And then there are the people who say in the background, what about low-hanging fruit? Why don't we do this? Well, the low-hanging fruit for Massachusetts was to get a healthcare equity office and to get a healthcare equity officer, which I think was good. But it only is as good as the person who's serving that role. And so I just wanted to put that plug in there. So these are all the segments that we kind of discovered in this long journey of healthcare disparities. This is not official. This is my collection of how you can divide it, and it also is a way in which ERAS can decide how you want to attack strategies to actually decrease healthcare disparities. Access is clear, social determinants of health, cultural competency, awareness, patient literacy, diversity of workforce, linguistic concordance, and I want to put a plug in here because I don't have a slide to go with this later, but linguistic concordance has a lot to do with medication adherence. You're going to actually ask the patient to adhere to some protocol prior to coming into the hospital, and you're not able to actually communicate effectively. Maybe the MARTR does an okay job, but Boston Medical Center did something really huge. Years back, they got people who spoke the same language, actually physical people, to navigate people through the healthcare system. So if you were Laotian, you had a mammogram, and you needed to come back for a biopsy, you would have someone, a Laotian, speak to you. And they would not only speak to you, but they might even consider doing something to facilitate you getting to the hospital. That's huge. And so they are in the thick of, I don't know if you've been to Boston, but if you go to Boston, there is a Chinatown with a lot of Asian Americans, and they looked at their community and say, how are we reflecting the community we're serving? The next step is, what does the governance structure of Boston Medical Center look like? Because only when you're reflecting your community in your governance structure can you have your finger on the pulse. And that is something that I feel fairly strongly about. And then the healthcare delivery system. So working in healthcare disparities, I decided I got to get in the public policy sector, because I'm not going to make a move until I can get to the place where I can do things a policy reform area. And I'm very fortunate to be having served as a Medicare Payment Advisory Commissioner. And on that commission, my goal was to put the patient in the center of the table. You have these Harvard epidemiologists, you have the actuaries, you have all these people with they publish in Health Affairs practically every other month. My goal as a provider is to put that patient right in the center of the room. So commonly they would talk about things like low-income subsidy, or they would talk about co-pays for hospice, which is, I wanted to go into status epilepticus when they say co-pays for hospice. Does that make sense to anyone? Yeah, scary. I have to put the patient in the middle of the room and say, how would this patient deal with this? I got a patient that experienced X, Y, or Z. And so they're only good, public policy makers are only as good as the people who come in the room who are next to the patients, who are in the thick of it. You who are in the trenches are more powerful for implementing policy and getting people to see what happens in the grassroots. And then biases. We're going to talk a lot about biases because I'm really interested in this. So, value proposition. This is really important. Society has to believe that good health for everyone is of value to the society. What does that look like? Well, you will have more people working, you will have more people adding to society, creativity, innovation, and job, workplace, and all of those wonderful things. So we need to think about diversity training, cultural competency, and how we deal with people once they hit the healthcare system, because that's really important. Now, Joseph Stiglitz is a healthcare, well, he actually received the Nobel Prize for economics, but it's amazing when he talked about the distribution of wealth in this country. If I have education systems, if I have government systems, and I have all the same type of people there, from Wellesley, not to go against Wellesley, but I'm not able to reflect the rest of the state of Massachusetts because I've eliminated the groups that would have come from the rest of the area, whether they're purple dots, green drops, or red drops. This is a concept that's really hard to get. There's a Gaussian curve of brilliance in every single group. When I eliminate all women, I've eliminated the brilliance that come with those women. So if you don't have different groups at the table, you've just eliminated the brilliance that comes with the groups. I value what they have to say, because in that group, there's some experience that I believe will contribute to the best solution, whether it's healthcare disparities, healthcare equity, implementations of new protocols. And I do believe that the system suffers when there's no diversity in governance. So I will share this story with you about the phenomenon of the Nobel laureate dinner. So I do Doctors Back to School, and a bunch of doctors get together, and this one doctor says to me, hey, I had a great time. I went to a Nobel laureate dinner. And I said, you can always learn from someone. So you're chit-chatting, and I said, what did you learn? And he said, wow, I went around, and he said about 8 of them, and I asked them, what do you think was the single most important thing for you winning the Nobel Prize? And he said, he was amazed that most of them had the same common theme, and that was this, that they took a discipline that they're not normally involved with, they went to someone else who was an expert in another field, they listened to them, their ideas, and their creativity, and their innovation, and they would come back and they would say, how can I use that in what I do? This is like huge. This is like disruptive innovation on steroids. And that's what disruptive innovation is all about, really. It's like a different way that's more efficient, that serves more people all at the same time. And I learned something from that just one encounter. It taught me something. We have to think differently. And in order for you to think differently, you cannot be entrenched and entrenched. Look at the things you're doing at your hospital. If it's the same old people at the same old table, you say, this is not the group. I don't know what the group looks like, but it's got to be a group that engages different thinking people. Groupthink is committing suicide to any protocol. And when someone says they don't allow you to put up the yellow sticker, you just thought of it, put it on the board, that actually kills ideas and solutions that might be the very solution that's there. One person anchoring at the beginning of the meeting, and everyone said, well, she said or he said, and everyone else is marginalized. Everyone else's ideas are marginalized. So this is what healthcare disparities is about. We have to think of different ways to do things. So I just want to quote a few studies for the impact of workforce diversity. First of all, increasing the supply of minority physician increases access to care. Okay, why is that? The AAMC did a study many years ago, and there are other studies since then to support this, is that minority graduates are twice as likely to go back to areas of low physician shortage areas. Black physicians practice in predominantly metropolitan areas. We're underrepresented in medical schools and in practice. About 1 million docs, we represent somewhere between 5% and 6% of docs in terms of African Americans, Latinos, Hispanics similarly. Asian Americans are overly represented, and Native Americans are really poorly represented. So if we want to really serve areas, and I'll give you some statistics about population in a second, but the other issue is, what about the nature of the relationship that Black physicians or Hispanic physicians share with their patients? There's evidence for improved adherence to medication, but there's also the nature of feeling more comfortable or rating your physician as excellent. It's not like, African Americans have a specific language, but if I say one type of words, a string of words, and the patient says another thing to me and I catch something, I'm gonna say, well, I know what that means when I was growing up. I know exactly what that means. And those are the cultural things that come out. This whole idea of people using woke, do you know where woke came from? It wasn't from a legislator in Congress. That's a grassroots term, and someone says, you're not woke, stay woke. That is from the hood, okay? So all of a sudden in Webster Dictionary, you're gonna see woke. And that's because of the diversity of people using new grammar, new words. So the anatomy of healthcare disparities. Let's talk a little bit about quality and safety. Our goal is healthcare equity. And ERAS does a great job of putting a roadmap there for what we want in terms of quality outcomes. The question I pose today is, if you're really, really good in ERAS, shouldn't your serious safety events go down? The other piece of healthcare disparities is this whole idea of decision-making and bias. We'll talk a little bit about that in healthcare literacy and patient empowerment. So for social context of barriers to healthcare, we talk about poverty, lack of insurance, physical barriers, limits in access to healthcare, education, language, cultural competency, all those things are important. But healthcare economics is at the bottom of it as well. You could take a poor black, a poor white, they both have bad experiences, and many health disparities will exist because of the sheer presence of poverty. As mentioned before, 1% of the population has 40% of the wealth in this country. And so the graph to your right will actually highlight the fact that African Americans, blacks in this country, earn about half, a little more than half of the salary of whites. But I want to bring up something else about the unemployment. So as a Medicare Payment Advisory Commissioner, 20 years ago, 4.5 working people used to support one Medicare beneficiary up here. When you have unemployment and you have all these other issues with disenfranchised people, guess what happens to the number of individuals supporting the Medicare beneficiary up here? It has gone down to 2. So what happens is you have progressive unemployment and you have people making less income at the bottom, is you have less dollars supporting that one Medicare beneficiary. Never mind, they may not get to the age to be a beneficiary of Medicare benefits, but it's just the notion that these people have been disenfranchised. It does affect the healthcare system. This becomes insolvent with time because of these people funding that process. So that's really important. I want to go on to healthcare literacy and empowerment. So Harvard Business Review did a nice study on employee resourcefulness and employee empowerment. So let's give an example. I know that I'm at the church and Dr. Johnson over there is a physician. And I just found out my son's been intubated because he has a swollen tongue from lisinopril. And I meander my way across the church and I said, my son's on that life support and he had a swollen tongue because he had a reaction to lisinopril and it's actually me. I said, well, don't worry. Angioedema is common, is not that common, but is more common in African Americans who are on lisinopril. And what we normally do is we wait until the person's swelling goes down and we extubate them and they do okay, right? Right? Another week at church, she meanders all the way across from her pew, all the way to my pew, and she said, my baby won't wake up. He's 27 years old, and they want to send him to the nursing home. I had cutis angina. I realized what happened. In that instantaneous moment, her son had a noxic brain injury from a respiratory arrest from angioedema. And the rest of the story is so sad. The 27-year-old guy dies as a result. But she had the nerve to come over to me to ask me. That was resourceful for her. The empowerment piece was the next step that happened. So people who are in the trenches need to be able to feel like I can get a resource, whether it's from the internet or whether it's from the person across the way at the church that you just went to. It's huge. So what's the best patient? The patient who is both resourceful and who's empowered. Do patients know what to ask? No. Do they know who to ask? No. And I'm going to talk about it in a few more seconds because we talk about biases, we talk about people's decision making. How you make decision has been framed, and these guys have won the Nobel Prize because they said there's 2 types of thinking. System 1 thinking and System 2. Please go out and buy this book if you haven't. How many of you know Thinking Fast and Slow? Anybody in here? Yes, yes, yes. I love this book because it explains half of the people you work with. It explains many of the bad outcomes that happen. And one of the things that you think about is System 1 thinking says, the bush is moving. There's a dog behind the bush. I'm going across the street. It's automatic. It's very fast. It's intuitive. If I saw a black man around my car 20 times, and if I saw a movie with a black man around a car who stole something, then I walk out in the parking lot, I see a black man around my car, I'm thinking, is this the same scenario? That's what you learn. You're not even aware of it. It comes to you naturally. And so some people have categorized this as racism, right? But I guarantee you a counterfactual could exist as well. And there is racism in the system, but this is thinking differently. I want people to see that thinking differently doesn't mean you consciously actually come up with thinking, I'm going to act like this. It's what you've seen in your environment, it's what you've done, it's what you've been exposed to, and how you react. So their prospect theory is men fear loss, or women fear loss, more than they desire gain. This is powerful. Because if you want to persuade someone at a table to do something, you will couch it in that. If I'm at the table, at the MedPAC table, and I know that I want this thing to happen, I'm going to couch it in fear of loss rather than love of gain. And so the same thing happens with how you negotiate for people to do strategies to decrease healthcare disparities, achieve equity, whatever it is, you want to advocate for whatever. But on the other side of it, it is also instrumental in our decision-making with patient outcomes. I could spend all day talking about this because it is the thought process, it's thinking. My whole year this year is think again. That's what my theme is. Think again. The moment you want to make something happen, just say, okay, I got to think again. Just go back to the drawing board. So it affects your perception. And there's something called the OODA loop. John Boyd's, have you guys seen this, the OODA loop? John Boyd's OODA loop. So it stands for observe, orient, decide, and act, okay? I see a man, I'm from Compton, so here's my example. I see a man with a gun, okay? That man has a gun. I've observed that. I orient. Oh my goodness, I better get out of here. Okay, I make my decision. I'm going to run. And then I said, okay, run. That's the OODA loop. I see healthcare disparities in my institution. I orient myself, something must be done. I decide what I'm going to do. I'm going to go to the CEO. I have a plan. I'm going to lay down an infrastructure. I'm going to attack it with the 6 variables that I told you that I would attack, you know, between access and all those wonderful things. Then I'm going to act. Well, it's not that easy, but at least you have a general conception of where you want to go with this. This is powerful. You know, this is one that you're doing nothing at home, you're getting ready to go to sleep, and you can't fall asleep. I want you to pull out the John Boyd's OODA loop and say, I got to get with this. This is where creativity rests, and it's powerful. It really is. But there are different things that will influence your progression from the first O to the second O, for the D to the A. All of those things are going to influence how fast you get to the action. And the same thing is true. This is happening on, I'm giving you a side for healthcare disparities, but this could also happen for a patient who rolls in the OR, a patient who rolls in the ER. You know, I think this patient can't see out of one eye. Is this a code stroke? Or is this that the patient has a sentinel or retinal artery occlusion? Should I call the ophthalmologist or the neurologist or the neurosurgeon? This same thing. This is, I don't know if John Boyd knows this, but he made me really happy when I saw this. So thinking fast and slow is distinguishing between unconscious bias and a faulty decision making, because they're not all the same. It's cultural based, that whole loop. How familiar you are, learned behavior, you know, habits, heightened awareness. Now, can you be a choice architect? Okay, so this is now I'm really excited, okay? Recently, we had a couple of events which were serious safety events. So I said, well, what can I do as chair? Well, how can I take that information that I learned at the Kennedy School and the book Nudge? How can I use that information to change behavior? Well, if the kids are at lunch and you want them to have celery sticks, you put them in the machine at the bottom for a nickel, and you put the Snickers up at the top for 25 cents, right? You don't have to do that. In medicine, you do something else. you put up some guardrails. So we've had a couple of incidences where the serious safety event was a result of a lack of escalation of care, that the person who's the primary provider did not call the attending physician. So put in the guardrails. I'm giving you a choice, not really, this is what you need to do. But if there was some kind of lack of ability to escalate, you need something that ties the attending into you've got accountability as well. So you do an accountability protocol to go with it. So the two can come together and it results in a better outcome for the patient. And in anesthesia, it's really important for us to just-in-time care is essential. It's like the tyrosine hydroxylase in the synthesis of dopamine, really. 2 minutes too late in the OR is a devastating injury. So, in talking about biases, they contribute to each one of these things. The biases that we talk about are powerful in that there's implicit bias, which we kind of talked about a little. It's subconscious. It's all that made you. Recency bias, and there's a great discussion about this into Mount Everest. Some of the biases that existed when they were climbing Mount Everest is, one, you know what, we're on a trek. We paid $100,000 to get the training for the preceding year to climb Mount Everest. Well, the recency bias says, well, no one's died recently. That's not going to happen to me. The next one is the confirmation bias. These guides are really good. They've never lost anyone. They're saying that, you know what, we're good. You're confirming that they are indeed good. And everything so far has led you to believe that they are good because nothing bad has happened so far. So you're looking in the system to keep confirming what you're thinking. All of these things play a part in healthcare disparities because someone may not want to do something for a Latino patient and they might say, well, he looks okay. I don't think he really has a ruptured AAA. He looks okay. He has had a seizure. Yes, I do know he has hydrocephalus. And you say, he's probably okay. I don't need to do a repeat scan. At 11 o'clock, he gets a scan and he's herniating. Yes, that's a confirmation bias. You're looking for reasons. And I tell my residents, what you have to do is you have to actually say, this is a hard question. How do I know that I'm not wrong? Did you guys get that? So how do I know that I'm not wrong? In other words, you've already decided what you think is the right thing. And how do I know that I'm not wrong anchors you on proving that you're not wrong, which is a very different type of thinking. And like I said, I'm really into this think thing. And then availability bias. As they climb Mount Everest, they're only dealing with what was available, the data and the information that they were available, and what was available with what the guides were giving them, and that information, you know. And then we talk about system 1 and system 2 thinking. I think I have a short amount of time left, so I'll kind of hurry along. The sunk bias, is this a timer for me? Okay. So sunk cost is the cost of pouring into people saying that I'm going to continue to climb Mount Everest because I already paid $100,000. Okay. The same thing happens when someone comes into the healthcare system, and this is unfortunate, but, you know, they're uninsured. Should we really be doing this? And I heard an argument, a discussion recently about someone saying they didn't take the vaccine. Why don't we give people priority in the hospital who took the vaccine? That's like a place we've never really been with scarcity, isn't it? So nudges, how do you put nudges in the system? I'm going to fast forward because I do need to cover some areas. Do racial disparities exist for surgical readmissions across a wide range of common surgeries? So this is a question that this study actually sought out to prove. Disparities in surgical 30-day readmission rates for Medicare beneficiary by race and site of care. If these disparities are present, are they primarily related to race? Are they primarily related to hospitals in which care they receive? Do racial disparities, surgical readmission exist, and are they mediated by poverty? Well, the last question everyone knows is true. Yes. So one of the things that really impressed me is that the study in the Archives of Surgery actually looked at different minority groups in New York City. And they looked at high-volume hospitals, and they looked at the surgeons that were doing the procedures. So it is now well known that minorities will go to a high-volume hospital and get a low-volume provider. In other words, you do 2 carotid endarterectomies the whole year. Someone else does 30. Which would you want to do your carotid endarterectomy? You want the higher volume. Does the institution control for or do a quality assessment on the people doing the low volume surgery? And it turns out that we don't do as good a job as we think. You know, and you could actually be practicing for 30 years. You were high volumes when you were a young whippersnapper at 40, but now you're 60-something, and you're only still doing 2 a year. You haven't really done a lot of CMEs because you said, I've been doing this for years. Nothing ever changes. Not realizing that there's some alternatives and there's also some better ways of doing things. I was impressed recently. Someone had bariatric surgery, one of my colleagues, and they had a disruption. And I thought, oh my goodness, hole in the stomach means they have to go back to the OR and they need a re-op. It's not true. I was embarrassed that they have different ways of treating people with dehiscence of their gastric sleeve. And guess what? It actually works well. And so part of this whole thing with high volume, low volume is who's keeping up with the data. And so this study and the next 3 studies basically talk about where minorities go and who they actually are taking care of once they get to the ivory towers of the world. It's not just a small community hospital. In many ways, a community hospital probably may be QAing their surgeons a whole lot more because of the sheer numbers is much smaller, and they're looking at the complication rates. So this is a series of 3 studies. They're really powerful. It talks about limb salvage surgery and the complications afterwards, termed major coronary complications or major complications with for advancement of their limb salvage surgery and winding up with amputations as a part of that. Looking at low volume arthroplasties, doc does, now everybody in this room probably understands that if you have someone who's doing like 2 knees a morning, 3 mornings a week, that person is going to be much more facile. He knows the equipment, he knows what he wants, and he has a whole lot of system 1 going on because he kind of understands it, probably could do a joint in his sleep. And then you get this one that says, I don't like that new equipment because we are now in the place where the DMEs or the durable medical equipment that's being utilized is all the same in one hospital because of the purchasing and how much people are trying to get a site with the same kind of equipment to decrease the error rate with instrumentation. So, I mean, there's some real issues with this. So looking at readmission rates, and this is a very interesting study, which looked at minority-serving hospitals versus non-minority-serving hospitals. So what do you think the difference was? Even when whites went to the minority-serving hospitals, they didn't do as well either. So it tells you something about the resources. But when minorities went to minority-serving hospitals, they had a higher readmission rate, and that was really important. And so Black patients suffer adversely whether they're in their own community and many times when they go outside their community as well. So that's an interesting study as well. I wanted to have this news flash, which says efforts at reducing disparity should focus not only on race-based measures, but also improving outcomes of care of minority-serving hospitals. So we need, even though someone says, well, is there bias? Are there healthcare disparities in systems that are minority predominantly serving? Yes, there is. And we had an awareness as a part of the commission that, guess what? Minority physicians will have biases and actually result in healthcare disparities just like non-minority physicians, but not as much. And it was just a poll that we kind of looked at. But still, because you're a minority physician does not mean you do not have biases and that has happened. And so I want to be honest and upfront so people will know that. So can ERAS do the hard task of eliminating healthcare disparities? Can you do that with ERAS? Everyone says yes. And this is one study that actually did that. And I love this study because it actually is, if you're going to advocate for money in your institution and you've got a large vulnerable population, take this study, put it in the center of the CEO's desk and say, this is what we should be doing. So what they looked at was postoperative length of stay. Secondary effects were looking at mortality and readmission. And here's what we have. So I wanted to skip through this slide really quickly. So you can see that the delta before ERAS is implemented, you have a delta of about 2.7 days. So you're comparing the O to E ratio, okay, the postoperative length of stay, the predicted for both African Americans versus whites. The predicted is very similar because it's risk adjusted. And then in B, you're looking at the delta of what exists pre-ERAS and then post. It basically eliminated the length of stay. Can you imagine what someone would say? 2.7 days, do you know how much that is? That's like more than a Louis Vuitton bag. It's $2,000 a day, okay? So this is amazing. A CEO should be interested in this. So we've gotten not only better care, but we got more efficient care, okay? Slightly decreased, was not statistically significant, and the dehiscence rate, okay? But underneath this, and I hate to do this to people in the room, but it does make a difference if it's a high volume, low volume surgeon, and it does make a difference whether or not people are making decisions about what kind of procedure you're doing for your colectomy and any kind of colorectal surgery. So, and there's a large body of literature that actually suggests that minimally invasive procedures are really where the money is because of decreased costs, efficiency, less complications, less dehiscence. All of those things are really important. Well, transplantation is ahead of the game. They for whatever reasons, they have done amazing work with liver transplantation. At our institution, we have probably, I think we're the 7th busiest liver transplant center in the country. But I recently talked with one of our transplant surgeons, and we have 70% of our transplant surgeons are African American. That's like huge, and that's disproportionate. 40% of the patients at VCU are African American. And so, and they pride themselves in good quality, and we are a center of excellence and preferred status in Virginia for transplant. And while COVID was happening and people shut down their transplant services, VCU kept going, and it went past anything. And this year, we've already hit our benchmark last year in the middle of the COVID pandemic. We've already hit that. We hit that by the end of October. So, and they made it a priority to have the best care for all the population that VCU is serving. So this is just a study actually looking at Hispanic outcomes, and guess what? Good results. Length of stay, discharge, all the other secondary outcomes as well. And you can see this, all-cause mortality and graft failure, very good. So, as I mentioned earlier, minimally invasive works, but there is discrimination as to who gets the minimally invasive hysterectomy, and people got to be good at it. You know, a doctor who's been doing open abdominal hysterectomies for years, he's going to still be doing open abdominal hysterectomies. Maybe you need to consider the minimally invasive hysterectomy. So I think that's really important. My slide will not fast forward, so I will have to go to, I'm so sorry, I will have to go to the notes and the challenges that I have for, so strategy going forward. Challenges, ERAS International should be addressing some issues. One is the health equity education. How can you make that a permanent fiber within your group, that you have a lens every time when you walk away from your meeting, that there's a health equity lens? Creating an environment for needs assessment and organizational performance. Establishing specific metrics and goals that ERAS says these are important for us going forward. Prioritizing actions that establish a timeline and an infrastructure that go with it. And I would warn you about the low-hanging fruit. Someone's going to say, well, this is low-hanging fruit. Can we go there? Be careful, because that's where we get stuck. And you walk away feeling good, and it only lasts for a minute. And so, lastly, I'd like to say that something that doesn't have funding with it is not going to help you. You need an infrastructure that's tied to the Benjamins, and I have a slide to that effect. Social determinants of health, they're important, and surgical decision-making is really important, but it's like you have to have an ongoing dialogue going forward. This is our ERAS care pathway. We now have 12 leads, 10 are primary leads, and I had to go to the administration and leadership and say, hey, we need funding. I need to support this. And they saw where it was really important, but there was one thing that was really good, and that we could say that we're going to show you that the AKIs have decreased. We're going to show you that analgesia compliance, normothermia, all of the things that we're following and trailing, they are looking better because of the implementation of these guides. So we had to put our money where our mouth was. We meet every week at 6:30 in the morning on Thursday. So we have a comprehensive program, and I think, it's one of those things that I think you have to really consider. Sit down, it's hard work. This is not a technical fix. This is an adaptive fix. It's working with the culture that exists at your institution. It's finding the key leads. And the biggest question I have is the impact of ERAS on serious safety events. And you cannot say that, the serious safety events are all one-off. It should be by the surveillance that happens as a result of ERAS results in attending accountability, surgeons, anesthesiologists, and also the primary providers that are at the bedside. It should be that surveillance, because of ERAS, allows me not to have some of the serious safety events that exist. And so I think we're moving fast, but if you want to move at lightning speed, propose to your leadership at the hospitals, hey, guess what? We have a way with ERAS to reduce serious safety events. When you get there, they'll start saying, well, I would really want to fund this because it's killing two birds with one stone. I mean, sorry, use that word, but it's attacking two things in improvement, and it will, as the studies have shown, and I have one with pediatric appendectomies, you will improve because of the surveillance and the attentiveness that people are actually getting to this level of integrity that they've never been at with following the patients through it all. So I'm going to end there, and questions, thank you very much. Sorry, I went over.
Thank you so much for that amazing and thought-provoking lecture. I'm sure you will, like me, think that's one of the most stimulating lectures I've had for a very long time. So thank you, Alice. It's a keynote lecture, so we don't take questions, but I'd like to present you with a token of gratitude from the ERAS USA Society. Thank you, Alice.
Thank you.